just by way of introduction, and I've known Dr. Ajayi for as long as I can remember. For those who are wondering whether yes, there is a relationship. He's like he's my cousin and he's like my brother. Cousins who are really that close that they could go for brothers. So Dr. Ajayi, MBCHB, MSc, deep occupational medicine, consultant psychiatrist, addiction psychiatrist, educator, and community leader. Dr. Ajayi is a distinguished consultant addiction psychiatrist based in the United Kingdom, recognized for a career dedicated to improving the lives of young people, families, and communities affected by substance misuse, mental health challenges, and trauma. With medical training spanning multiple continents and over 2 decades of clinical teaching and leadership experience, Dr. Ajayi brings a deeply compassionate and culturally informed perspective to the field of addiction and public mental health. Dr. Ajayi's cultural expertise covers a broad range of areas: adolescent substance misuse, dual diagnosis, neurodivergent mental health, trauma-informed care, harm reduction, and family-centered recovery models. His practice is rooted in the belief that understanding, not judgment, forms the foundation of healing, and that every young person deserves access to safe, evidence-based, and culturally sensitive support. Beyond clinical work, Dr. Ajayi has an extensive record of service in education and mentorship. For 17 years, he has mentored African medical students in Hungary, particularly in Budapest, Szeged, and Debrecen, and continues to support graduates throughout his role on the board of trustees for the Szeged Medical Graduate Alumni. Dr. Ajayi's influence extends into community leadership and faith-based settings. As church secretary, choir member, and part of leadership team at the New Covenant Church, he integrates principles of compassion, restoration, and service into both his personal and professional life. His work across the UK, Africa, and the USA has positioned him as a bridge between cultural, religious, and medical perspectives. He's married and has a daughter. And I will dare add that daughter is now a qualified doctor herself. So there's some generational greatness here. And so with a very warm welcome, please let's welcome to Tripartcare tonight, Dr. Olaniyi Ajayi. You are welcome, and the floor is yours.
Thank you so much, Taiwo, for that very warm introduction. And I thank everybody for attending today and for Tripartcare. Wow, well done, 5 years. And what an awesome job you guys are doing. And I also appreciate your backup team, because I know this is not only about you, for the wonderful job you guys are doing. Hopefully tonight, I'm trying to give an overview on alcohol and drugs. I hope you can see my screen. Let me try and put that in the
presentation.
To try and give an overview of alcohol and drugs generally. We cannot touch anything in details because there is so much to touch, but I'm going to focus on some of the common themes that we're having now in the young adult population and some of the concerns we're having with socially acceptable substances, and also the new trend in things like vapes and things like that, and the risk associated with this. And also talking briefly about chemsex drugs. So what I've tried to do is that I don't usually show all my slides, but tonight I am doing that. But I also want us to just focus on the red part of those slides to kind of identify the most important bits from each of those slides, so that we can cover as much as we can in the little time that we have. So, and hopefully we'll have some time for questions at the end. All right. And I'm so appreciative of other professional colleagues on the platform today. Like Taiwo said, I'll probably be running to you when I need help to answer questions. All right, then. All right, let's get started because of time. So basically, we're going to be covering a lot, and that's what that slide is just about. When we look at the UK substance misuse key statistics, I'm not actually adding a lot about the global one now, because adding the global one can actually be very, very scary when you begin to look at it. But when you look at the prevalence of substance misuse in the UK, 8 million You just say millions, 2.3, 5.4, and alcohol-specific deaths in England in 2023 is about 8,000 plus, which is the highest since 2006. And one of the problems we have with some of these substances, especially alcohol, is the fact that alcohol is socially acceptable. And that is what makes it the most difficult substance to treat and the most dangerous and the most important drug that causes a lot of morbidity and mortality. When you look at alcohol specifically, you will find out that a lot of people don't even regard it as a drug. In my practice over the years, what I've found is that the approach of male and female to seeking help for alcohol differ a bit, because you have a lot of women that will present to the GP practices, which is their primary health care physician, and they will not talk about alcohol, but they will talk about non-specific symptoms, headaches, poor sleep, body aches, and all that, and they just keep getting all different medication being prescribed to them, aside from actually tackling the main problem. So when they come to people like us, they are already moved into the stage of complications. So when I talk about substance misuse generally, I talk about 4C, C for Charlie. We talk about people craving for a substance. We talk about the compulsion to use the substance. And we talk about loss of control. And if I may add, once people lose control of managing a substance, that control is lost for life. You can only manage that loss of control, which means that the psychological dependent part of that addiction problem has to be a long-term, lifelong therapy support. And so, which is why you find out that most people actually are in denial of the fact that they don't have control. But then you continue to do the same thing, you will get the same result. So the last bit is what myself and my team and other colleagues on the platform who work in addictions always want to prevent, and that's complications, which we'll look at some of them as we go along tonight. So let's start with alcohol, in case we don't have time to look at the other ones. Let's start out with the main one. The mechanism of actions, I won't boss on that a lot, but what we need to understand is that the impact of alcohol on the body system, the mental, the physical, and the emotional health is significant. And especially in some countries, I'm from Nigeria, for example, and I know that a lot of the alcohol that is sold are not properly distilled. And what you find is that people are actually thinking they are taking alcohol, whereas they are taking methanol. And that's why you have a lot of people coming down with kidney problems, because the unrefined, or if you have alcohol that is not properly distilled, the constituent of the alcohol or the oil at the end can be very, very dangerous to the body, especially the kidneys. And I'm not surprised that we're having a large proportion of young adults and men, especially, coming down with kidney problems across Africa. And that's one of the things we need to be tackling. And I'm very pleased to have some of my colleagues from different parts of the world on the platform today, so we can check this back and begin to focus on this. So before, we used to have a different guideline for men and women, in which we say 21 units for a man over 3 days and about 3 days free a week. But now we know that the dangers of alcohol has actually made that reviewed. And we now say 14 units for anybody, whether you are male or female. It's the safe unit. Anything above 40 units a week, you need to be looking at whether you are harmfully using alcohol, or you are abusing alcohol, or you're becoming dependent on alcohol. So those are just some of the units of alcohol in the UK. But what are the things that can actually happen when people become dependent on alcohol? A lot of people think that because they can still walk, they can still talk, they can still communicate, then they are safe to do certain things, work on machineries, drive cars, and things like that. That is actually just a belief that is not clinically supported. Because half of the time, when most people drink to a certain level, they lose the ability to control certain aspect of their life, especially cognitively. They have a low response time. They are more at increased risk of having accidents. They are more increased of having road traffic accidents, violent behavior, and then other things that can happen to the organs, as I've highlighted in the slide, which I won't go to one by one. But I want to mention something under the cardiovascular and the other. We talk about fetal alcohol syndrome disorder. And over the years, we've thought that it's only when the woman drinks during pregnancy that this can be a problem. Actually, we now know that there are evidence to show that if the man also drinks a lot and is dependent on alcohol and actually impregnates somebody, that child can be at risk of having fetal alcohol syndrome. That tells you the impact of alcohol and some of the things that alcohol can actually lead to. So it's extremely important that we manage this, because unfortunately, people manage a lot of emotional, psychological, stressful situations by drinking without realizing they're actually drinking beyond the recommended units per week. These are some of the things that you will see in terms of withdrawal and how we treat alcohol, and the medication that we use and things like that. We'll talk about the kind of support system that is outside there for us towards the end. So let's go to cannabis. More common in younger people, but actually we're now finding out that actually older adults also indulge in this habit, in their own closet or on a one-to-one without people knowing it. And they use it to manage stress. Some people say they're using it to manage pain. Cannabis is a misunderstood drug that is extremely dangerous. And so when I speak to people about cannabis, one of the things I try and establish is that where is the source of that cannabis? Because if you're buying cannabis from the street that is kind of cultivated in an open air field, it's different from a cannabis that is cultivated in the house, and it's different from a cannabis that is cultivated in water. Because what we're talking about, that the ingredient, which is tetrahydrocannabinoid, the level and percentage determines how strong that cannabis is. And the more you stop fertilization taking place, the more the strength of the cannabis that you're buying. So, for example, if somebody has cannabis that is bought in the house, fertilization does not take place because it's been taken out of the open field. So the female plant is actually the most potent. And so when you have cannabis grown in the house, and if they're grown in water, again, it increases the THC content. So it can be so lethal. So, for example, somebody who buys from a dealer who cultivates, or buy from somebody who cultivates in an open field, and then unfortunately buys the stronger one without realizing it, can actually have a lot of other side effects or complications from using that strong cannabis that they're not used to. So these are some of the things that might be relevant. But one thing I want to point out, especially under the mechanism of action, is the impact on the hippocampus, which is where our memory and things like that are generated from. The frontal cortex, which is also the brake for us, where our executive functioning comes from, and which gives us the ability to be able to make rational decisions. And the basal ganglia, which is responsible for repetitive behavior. We talk about the CB2 because I have a lot of young people coming to me and say, I'm using cannabis for faith. I'm using it for my depression and anxiety. But actually, medicinal cannabis, which we'll look at, is different from normal cannabis that people smoke on the street. Because we'll see the difference very soon. They're totally two different things. They're not the same. So buying cannabis for medicinal use is actually not right, because the medicinal cannabis is more of CBD and does not have a psychoactive impact, or if it has, actually it's extremely minimal. So we cannot equate that, and most youths will do that and they get themselves into trouble. But one thing that also is important to note is the fact that we now have different forms of cannabis that is coming out on the streets at the moment. Usually people they think about the weed and the green leaf, but then we now have the edible form. We have the oil. We have all sorts of other forms that can be used in the vaping machines and things like that. And ash oil, for example, will not smell, does not have a smell, and people could actually be using ash oil beside you in a vape, and you will not even know they're smoking cannabis. So all these are some of the challenges that we have in substance misuse services, how we manage this. So I've mentioned some of the types and preparation that you can find, like the herbal cannabis, the skunk, and the weed, and that is got a variable percentage of THC, which is the active ingredient, between 5 to 25. I mentioned those that are grown in the house. The ones grown in the house and the one grown in water can actually range up to 28 or sometimes more THC content, which tells you how potent these things are. We used to think it was the skunk that was the most strong, but you're talking about black manga, sweet squeegee ink, and lots of other names. Just don't worry about the names. I'm just talking about the different forms of cannabis that are available. So cannabis oil, wax, and all those things can have THC up to 80 to 90%. And if anybody gets hold of that and they're not used to smoking it, they will go crazy completely. So, and that's why when people are getting indulged in this thing, you just don't try it with friends that have been smoking for many years. And I've actually had friends, patients or clients that have used cannabis for a long time, and they just go to visit a friend who is smoking cannabis and they have a psychotic episode. So nobody's immune against the psychological impact of cannabis. And it's extremely important we know that. People can smoke it for many years, but then one day they might actually just perceive it as second-hand smoking and develop a psychotic episode. And we see some of the side effects that are quite distressing. Okay, we're talking about what people get from it. The euphoric effect, the relaxation, that's fine. People talk about what about the altered time perception, the anxiety, the paranoia, the panic attacks, the impaired short and long-term memory, the fast heart going, the conjunctival injection, the increased appetite, sometimes that people call the munchies. But most importantly, there is something that is controversial but recognized that can affect a lot of people. And they might be presenting to my other colleagues who are adult psychiatrists and saying, I just can't get myself motivated. And it's called amotivational syndrome. It is quite distressing for a young adult to know what to do, but just can't do it. And it's not depression, it's not clinical depression, it's not anxiety, it's just the side effect or possible complication of long-term cannabis use. And it can be very, very, very distressing and very, very difficult to manage also because they don't necessarily respond to antidepressants and all the other measures except psychotherapy and some CBT that we might talk about later. So what are the kind of side effects that you can get from cannabis? Chronic bronchitis, even cannabis-induced vomiting is another thing of feeling sick. Severe vomiting relieved by only hot baths, but people might not realize that when they feel sick and they go into the shower, they feel better, not knowing that actually it's related to the cannabis. And cardiovascular problems like irregular heartbeats, which increases the risk of having a heart attack in young users. And I mentioned the impaired fetal development that can lead to what we call fetal alcohol syndrome in alcohol, but you can also have fetal development problems with cannabis use and pregnancy. So that is worth noting also. And impaired adolescent brain development. It's important I mention something here that addiction is an adolescent disease that actually starts from the very young age. And we must not forget that the brain is still developing up till the age of 25. So when somebody starts using drug at an early age, it will definitely have a difficult brain development. And the frontal lobe that I mentioned is the break for us, is the last that develops fully. And this is about around the age of 25. So you can imagine somebody starting to sniff glue at the age of 6 or 7 and using other drugs as they go along up to the age of 25. There will be a lot of cognitive deficits. But unless we do a complete neuropsychological assessment, we might not know where those deficits are, but they might begin to impact the life of the person as they grow into their adulthood. So we know that 9% of users of cannabis actually have what we call cannabis use disorder. And when we look at this, because it is socially acceptable in certain groups of people, and people use it for different reasons that they try and justify, people don't really come for help. Hardly would you find somebody coming to a service like mine and said, I've got cannabis use disorder, but usually it might be a combination of polysubstance use. Maybe alcohol is the most debilitating substance, and then you realize that they're actually using cannabis at a very, very detrimental level also, in which we need to also interfere with that. Over the years, because of the difficulty getting access to drugs, dealers have now gone into the lab to create exactly the same chemical form of every drug that is available. So when we talk about spice, this is synthetic cannabinoids, mostly from plant fertilizers, I would say, that are now developed in the labs to kind of imitate the normal cannabis that are grown. And these are extremely dangerous. Extremely dangerous. We call them synthetic cannabinoid receptor agonists because they are chemically unrelated to cannabis, But unfortunately, they target the same receptors that cannabis act on. And this are sold in the community as Spice, K2, Black Mamba, Annihilation, Clockwork Orange. Even the name itself is scary. So you can understand, because what they do is that they spray herbal materials and give it the impression that it's cannabis, and then they sell it to people who are very ignorant of what they're actually buying. And so we know that this is a full CB1 agonist, that it stimulates the CB1. Whereas cannabis itself, the THC, is a partial agonist. So when you have a full THC and CB1 agonist compared to a partial one, you will understand the reason why the impact of spice on people is profound. And some of this, I don't know whether you've seen some videos in America or in Newcastle that they've shown, like where you just see somebody standing transfixed on the spot in a zombie-like state. That is spice. And they might be in that position and become hypothermic or hyperthermic and have seizures and die on the spot without moving. That's how bad this drug can be. In addition to the risk of having fits and seizures, increased heart rate, hypertension, increase in what we call the QTC prolongation, which means that the heart goes to sleep longer than it should before it starts to pump again. And the heart might actually not start pumping again and they might die. And also acute kidney injury, vomiting, abnormality of the clotting system, in which it makes people more vulnerable to bleeding to death if they have any form of injury. So these are some of the things that are available on the streets and that most of our young youths are exposed to. So I mentioned cannabis use disorder and medical cannabis. I'll just run through these differences quickly because there is always this belief by young people and young adults that they're the same. They are not the same. Medical cannabis is strictly regulated. You need a license to prescribe it. You just cannot prescribe it, and it's prescribed for different things that you can see in red on the green side. And whereas cannabis, we've talked about it, and you can see the impact of it. It's not regulated. It's on the street. Even dealers don't know the potency of what they're selling. They just get it and sell it to people. But what we know is that 9% of all cannabis users would develop a disorder or dependence, has risen to 17% with daily use and up to 50% in adolescents in the UK. That is a worrying figure for us as addictions psychiatrists and even my colleagues who are adult psychiatrists or child and adolescent psychiatrists, because we're now seeing the overlap between mental health and substance misuse. And we know that it's very, very difficult to tease out which came first and which, you don't know which one is the chicken, you don't know which one is the egg. But what we know is that both of these lead to what we call comorbid substance misuse disorder and mental health disorder. And I'll talk to you about the wheel if we have the time, but I can mention that briefly now. When people develop what we call comorbid substance misuse disorder and mental health disorder, they are two different disorders. It used to be called dual diagnosis, but that in its own caused a lot of problem in terms of the commissioning of care for those people with both disorders. So that's why we now call it comorbid, showing clearly that there are two different disorders. It's almost like you have a bicycle. If you have a bicycle, you can turn one wheel as fast as you can. That bicycle is going nowhere until the second wheel starts to move. If the second, it can even be moving slowly, but as long as it's moving, you're making progress. And that is why sometimes we do get into this debate with our colleagues in mental health about, which one should we take? If we don't try and manage the active symptoms of the mental health disorder, people like us who work in substance misuse can do nothing, because we cannot even shift the client because they are self-medicating most times with a substance. And when we get to ketamine, we'll actually see why substances can be so damaging. The ketamine cystitis that we see, the only thing that manages the pain effectively is more ketamine. And what damages the bladder is ketamine. So you can see how people try to balance this and they find themselves in a very difficult situation in which they cannot easily get out of it. So if we just move on to the next slide because of time. So these are just the things that differentiates the cannabis use disorder from medical cannabis. And we can see that the high THC is quite important and low CBD, but more higher CBD ratio with what do you call it, with the medicinal cannabis. And it's also mostly in oral form, capsules, oil or wafer or sprays. And whereas you have cannabis that can be mixed with all sort of things, vapor, oral edibles, and all sort of other vehicles of use that can cause increased like pneumonitis, lung problems, and other chest infections. So that is just a brief comparison of and these are things that can, the side effects and what the cannabis can lead to, whereas the medical cannabis has minimal effect on these things. We use them to actually improve the mental disorder, not add to it or complicate it like cannabis would do. So, electronic cigarettes and vaping. This, for me, is one of the areas of interest at the moment because I tend to get people coming now to me who are addicted to vapes. And I ask them, when did you start smoking? And they will tell me they've never smoked before. And I'll say, how long have you been vaping? I've been vaping for 10 years. Why are you vaping if you've never smoked before? That's the kind of things that all these substances that just come into the community that are not properly controlled can lead to. So you have young people, you have young adults, you have elderly patients that are vaping rapidly that have never smoked. And so what you find is that the e-liquid that is sold is very, very easy to have contaminants. It's very, very easy for people to adulterate it and actually bring in fake form of it, which we have a lot. I'll probably say a large proportion of young people who don't have a salary or have any form of income are buying the dangerous form of vape machines or vape liquids because they can't afford the real thing. So most of the things are sold under the tables in off licenses. So you now have cigar-like vape machines, you have vape pens, you have pod systems where you can put cannabis seeds or cannabinoid oil and smoke it. But one of the things that you have with the vapes that also makes it more likely to cause respiratory problem is the rapid nicotine absorption comparable to cigarettes. And that is why you have this sudden dopamine release in the nucleus accumbens. Basically, the nucleus is the reward center. And that's what gives people a kick when they use substances. And that is why it's highly addictive because of that massive dopamine release, rapid nicotine absorption that they get. And some of the salts that are sold are of high concentration, 20 to 50 milligrams in some UK, higher in some illicit devices. That is a big worry because what you find is that it causes dependence. Apart from dependence, it also causes a lot of e-cigarette vaping associated lung injury, which some of my respiratory colleagues will talk about at length, but that's not my area of specialty. But you do have those who contain vitamin E acetates causing more injuries. And also airway inflammation, bronchospasm, cardiovascular problems due to the impact of nicotine on the heart itself. And then other things that are contained in these things can include heavy metals, such as cadmium, lead from eating cause that is used in the process of making it, and the flavorings also that can cause bronchiolitis. So these are the things that we're dealing with. 9% of secondary school pupils between 11 and 17 vape. And this has risen from 6% in 2018 to 2023 to 9%. And I'm sure if we get the 2026 statistics, I can say that will have probably doubled. Because at the rate in which we are finding vape machines being seized in schools, and the Spice vape machine is so tiny, it looks like a USB Bluetooth device that you can even hide in my beard if I'm going to school without anybody seeing it. So it's very, very easy to conceal. It's very easy to take into places, but it's extremely dangerous, especially the Spice. Going to ketamine. Ketamine acts on the glutamate receptors. And when we talk about the glutamate, it's our excitatory enzyme in the brain. And that's why you find out that it's licensed for anesthesia and analgesia where people use it. And for those of us who trained back home in Africa, and I know also sometimes it's still used in anesthesiology in most countries of the world, it's used for manipulation under anesthesia, in which we give people ketamine to be able to reduce their shoulder dislocation. But remember, in those days, people hallucinate a lot, and people will be talking about their escapades while they're under ketamine. And thank God some wives and family are not in the theater, otherwise, things would have happened. But then people hallucinate, and that is the effect that people are enjoying now. And so it can be snorted, injected, but the oral form of it is kind of slower in onset. So people don't really enjoy that. And that's what we call the booty bombing, in which people can also pass it rectally. What are the recreational effects that people enjoy? The sensation, out of body experience, what we call KOLE, in which at very, very high doses, people can actually feel as if their body is leaving themselves, and they can go into a catatonic state in which they can't move. And people sometimes will call it sleep paralysis, but actually it's actually not. It's a side effect of ketamine use. And they can be extremely euphoric. That is, the very hyper aroused. And they can hallucinate. They can have perceptual disturbances, like seeing things. I know they're hearing things, thinking they're in a different area, whereas, or not even remember where they've been. And that can be a side effect that can be distressing. But one of the dangers for this is the impact of ketamine on the urogenital system. So it can cause what we call ketamine bladder syndrome, in which you have severe ulcerative cystitis and reduced capacity of the bladder. I have seen somebody with a capacity bladder of 50 or less with ketamine bladder and extreme pain. And when I'm talking about pain from ketamine bladder, you're talking about extreme pain. And upper urethral tract infection, affection can happen later on, like hydrourethral hydronephrosis, when the impact of the ketamine use goes to the upper urinary tract system. Papillary necrosis, it can also affect the liver. When you begin to have upper respiratory tract infection, then you begin to have alteration of the kidney functions. When we do our U&E to check the kidney functions, you begin to have affectation of the liver function test due to the damages that you can find. One thing that people tend to talk about with ketamine that is distressing is hallucinogen persistent perception disorder. If the visual hallucination or the auditory hallucination, hearing voices, is acute, they enjoy it. That's what they want from the drug. But when it becomes persistent, it becomes quite distressing. And that's when they actually might go and meet their GP and say, I'm seeing things and I'm hearing things, or I'm having flashbacks from things. And also psychological dependence can continue to lead to compulsive behavior based on what I said earlier on, because it's only the use of more ketamine that manages the pain. So one of the things that we are trying to do within the community drug and alcohol service is to work with our urology colleagues and have a quite of seamless referral process in which we can work together to manage the pain, because it's only management of the pain aggressively that will lead to reduction in the use. And in my experience working in an inpatient detox unit, my approach was quite different. I never used any habit forming drugs to manage the pain, but we had conservative management pain protocol that was solid, including things like acupuncture. We had the TENS machine. We had exercise, pelvic floor exercises, and I aggressively treated the cravings and the anxiety. Once you treat the anxiety to a certain level, because the anxiety increases the perception of pain. And so I observed that treating the anxiety aggressively also reduces the perception of pain, and it helps them manage the cravings better. Because initially we struggle to keep people in treatment because they will come and then walk out of the residential detox because of the pain. But when we put a few things together based on our experience, we are able to retain quite a significant amount of that. At least 90 to 95% of our clients completed their treatment. So that was a quite positive thing that we achieved there. Chemsex drugs is becoming more popular. And within the UK, for example, prior to COVID, most of these things would happen in Seoul and in central London. But because of the restriction in movement, you started to have regional sex parties, regional groups and club parties happening, and it's now becoming local. And you are now having availability of some of the chemsex drugs that I've listed here, things like ketamine, MDMA, ecstasy, cocaine, and all those things that are used. What are chemsex drugs? These are the use of specific psychoactive substances to facilitate, enhance, or prolong sexual activity. And you find this more in the groups of people, men who have sex with men. And so it's more prevalent in that group of people. And that also includes things like primary chemsex drugs. The big three are mephedrone, GHB and GBL, and crystal meth. Mephedrone is a dangerous medication because it's a chemical drug. And people tend to inject it because they get a quicker effect from it, but then it can cause necrosis of the skin and actually heat the skin up to such an event that people have massive ulcers that will refuse to heal. And that's one of the side effects of mephedrone use. GBL is dangerous because it has a narrow safety margin. And they come in liquids that has to be topped up every 1 to 2 hours, but exceeding the dose can actually really overdose and death quickly because of the narrow safety margin of it. Just like some of us will know that lithium also has that same issue that we use for people with bipolar and mood disorder. But in GBL and GHB itself, it's extremely dangerous. And that's why community treatment for GHB above 4 mils a day is unsafe. They will usually need an inpatient residential setting. Even for 4 mils down the line, it has to only be done in somebody who is actively and very motivated to engage in psychological work for us to even think about a reduction plan in the community. Most people will be referred to a residential detox unit. How are we doing with time, Tayo? Are we good?
Yes, we are. We
right.
still have 20 minutes.
Oh, brilliant. All right, thanks. And then, so one of the things you find in people who engage in chemsex is this. And for people who don't actually know what chemsex is, it means that men, either on Tinder or gay sites, will just check out parties, go there, use drugs. They can be there for 3 days, have indiscriminate sex with other male partners without protection. And these are the people that will use the pre-exposure prophylaxis for HIV. Some of them don't use it, and some of them know that they're positive. So all stuff risk out there. HIV positive men who are having sex with people who are, people with hepatitis C who are also doing the same thing and injecting and slamming. We call injection of all these drugs slamming. And then most of the time they share needles, they share works, and they don't care because of the impact of the drug on their ability to think straight. So their increased risk of infection, such as HIV and hepatitis C and B and all those things, are very, very high. So we've talked briefly about mephedrone, and I was talking about GHB in particular. And I will just quickly talk about the loss of consciousness, the respiratory depression, and the risk of going into coma because of that narrow index of that. And crystal meth that people call TINA and all sort of other things can also cause paranoid psychosis, cardiovascular problems, neurotoxicity. And the problem with methamphetamine induced psychosis is that it may persist for weeks and months post stopping of it, which now becomes a diagnostic dilemma for my colleagues in adult psychiatry when they see people in psychosis. And they're saying, but you've not had methamphetamine for 4 months or 3 months or 2 months. Actually, you can still have the impact of a methamphetamine-induced psychosis for months when they use it. We don't know the class of people or the category of people that fits into this group, but we know that that can happen. And so talking about HIV transmission and all that with the chemsex, we've talked about that. One of the things that also happens with people who use stimulants and is calm down. When we find people with depression, for example, and we treat them properly, either with psychotherapy, CBT, or we use medication to treat them, their mood will level back to the normal functioning level. That's what we expect. But with people who use stimulants, when they go high and they drop beyond their normal mood level. So they crash. And that's when suicidal ideations, intents, and actions are likely to happen. And which is why when you find people who don't know how to learn to manage their crash, as we call it, or calm downs, they are actually more prone to presenting an accident and emergency and in A&E. But the other part, let me rephrase that. The other dangerous part of this is the social isolation and shame and stigma that goes with using these drugs. That increases the risk of suicidal ideations, intents, or plan. So we try and find out what people do when they're coming down. I must add that sometimes people manage their coming down with substances of abuse also. So people will use things like alcohol, cannabis, benzodiazepines, Zopiclone, and things like that to calm down, to make sure that they have a smooth ride when they're coming down from the stimulant rather than having the crash. So what I mean by smooth ride is that they don't go beyond their normal mood. They just have almost like a curved graph when they're coming down, as opposed to just crashing down and then having this dip that they can't manage, and they can take this before they get back to their normal mode. So for GBHB, like I mentioned, accidental overdose is high. In other drugs like methadone, cellulitis, septicemia from injection, and this is very, very common with chemsex drugs in chemsex parties because they have no concept of harm to others or harm to themselves. So sexual trauma is extremely high. Rectal tear and also other things can happen, and because they also have a reduced pain perception. So when they are even being harmed by other people, they don't perceive it until the high comes down. So those are some of the things that we find in people who use chemsex drugs. I must say that for people in the UK, if you find anybody that needs advice, 1516 Road is called the Clash Clinic, and they can help support people with chemsex addictions, basically. So what do we call novel psychoactive substances? This I'll probably just touch on briefly. These are chemical form of drugs, basically, like I mentioned earlier at the beginning of the talk, that every single drug that you have, whether they're depressant, hallucinogens, psychoactive substance, that is a chemical form of it that is sold online or sold in the dark web. So every single drug that you can find has a psychoactive substance there. And that's why legal highs, even bath salts that our mom put in our bathrooms and toys, are actually what they're novel psychoactive substances. People use it and it can be extremely dangerous. And why are novel psychoactive substances particularly dangerous? One, their rapidly changing chemical composition evade detections. So we can't even develop urine drug screen or blood test to actually find out what the chemical that might be causing the problem is. Also, they have unpredictable potency because there's no quality control. Even the people creating, for example, the spice, the drug dealers don't even know the potency of what they're selling because they don't know, and they don't really know. And then we also have limited or absent human clinical data because I mentioned earlier on that most of them are actually plant fertilizers and dangerous chemicals that are not meant for human consumptions. And you also find clinicians and toxicologists unfamiliar with the presentations. So when, for example, I call the poison control and I say I have somebody who is used a novel psychoactive substance, now we're probably getting more evidence that we're trying to build up a cache of information. But before, they will not really know what to tell me to do because they're not familiar with it. It's not been tested. We don't know how they present. We don't know what they've taken. It's so difficult, which means management of that kind of drug use is very, very difficult. And also drug checking services and analytical resource are increasingly important, but we don't have this for the novel psychoactive substances. So if I'm not sure of a drug, for example, I can send it to the lab for them to tell me the actual constituents. But if it's a novel psychoactive substance, they might not even have any ingredient to test for it. They might have no clue what we're trying to test for. And most of it are marketed as legal alternative to controlled substances. So the dealers market it as an alternative because it's easily accessible, it's cheap, a lot cheaper, and that's why ketamine is more prevalent in young people now because ketamine 1 to 2 grams can sell for 5 to 10 pounds, whereas they're not going to get original heroin or crack or cocaine for that same amount of price. So the availability of these drugs make it more likely to be used by young people. I'll just go to the opioids. The fentanyl analogs, especially, is extremely dangerous. They are 10,000 times stronger than the normal morphine used in hospital for acute pain. So the risk of accidental overdose is extremely high, extremely high. So that's why in America, I'm sure we've all heard about the fentanyl epidemic and even the oxycodone thing and all that. But fentanyl is an analog, and some of this analog that people sell as chemical is carfentanil, and it's extremely dangerous. And the reversal medication that we have, which is a lifesaver for us in substance misuse, for opiate overdose, does not reverse some of these analogs. And that's the problem. So sometimes what we do is to give people multiple naloxone to continue to use until emergency services come. And sometimes we've been lucky, we've brought them back, but because we don't actually know what they're buying off the internet, it's very, very dangerous. But it's still safer to try and manage out with whatever we have until emergency services come. And I must mention here that a lot of the drugs that are marketed with PAM at the end that sounds like benzodiazepine are actually not benzodiazepines. A lot of it are stimulants because they are novel psychoactive substances. And people get attracted to these drugs because they have AM or LAM or PAM at the end. And people who are addicted to benzodiazepine think that they are buying a substitute, but it's actually not correct. Gabapentinoid has also been misused and it's been reclassified in 2019. Pregabalin and gabapentin, for example, we now know that extremely addictive. Pregabalin is extremely addictive and so difficult to come off. Actually, people find it more difficult to come off other illicit substances than coming off pregabalin. So we are working with our local pharmacy commissioners and our GPs to try and see how we can get people off this medication safely, because the risk of seizures are also high with pregabalin, so as with diazepam. Some of these things we've mentioned, but what you can have with acute clinical presentation is something called rhabdomyolysis. And when people are doped up with medication, they can be in one position for almost 48 hours and not even get up. So their muscles, they lose muscle mass, they release all sort of things from the muscles that can actually cause kidney injury. And then they can have all other side effects that I've mentioned here, which we will not go through because of our time. But so it's worth mentioning about the impact of neurodiversity on stimulant users. Over the years, and this is one area of interest that some of us are now actually becoming obvious to us, because the problem with this is that initially, and I got to have interest in this almost about 12 years ago, when I used to have a dual diagnosis clinic, and I would see able-bodied professional men that are going in and out of prison. And I could see traits of ADHD and ASD, and I will admit the DIVA scale. The DIVA scale is just a screening tool, and you realize that they have clear symptoms of neurodiversity. We refer them to the MOTSI then, who was local assessors for us, and they will assess and put them on medication, and their life will change. I remember one client that even refused to be discharged until I came back from annual leave because he has spent 10 years in and out of prison. And after getting treatment for his ADHD, he was able to hold on 3 jobs, get married, and have a child. That can be the life transformation if you get it right. But if we get it wrong, these people will continue to suffer. And hopefully, with some of the evidence that is coming up now and some of the experiences of some of us working in addiction psychiatrists, we can continue to support this client group. So I was talking about the wheel, the 2-movement wheel. So the problem with our treatment model for substance misuse is that there is no wrong door. There's no wrong door. And that's why we have an open door policy. And every client that has a substance misuse disorder, people tell them you can just stop it, you can get over it. No, it is a disorder. That means the ability to order the use has disappeared. It's become an illness, just like we treat hypertension and any form of other illness. It's the same way we treat substance misuse. It is different if somebody is misusing substances and you say to them, you can stop, you can use other means and all that. I am not talking only about focusing on the medical model, but we also have the psychological model that is the most crucial part of treatment. Because when you talk about the two arms of addiction, you're talking about the physical dependence that make people go into withdrawals and they want to continue to use the drug. So it's almost like a perpetuating factor for them to continue to use the drug. But then you have the psychological dependence that keeps them in the addictive behavior. Because unless they address that psychological dependence, they will continue to relapse. And that's why substance misuse itself is a chronic relapsing disorder. And anybody who does not come to the conclusion within their own mind that it is a lifelong treatment will continue to relapse and get better, relapse and get better. This is more important with alcohol, because alcohol itself, the more people stop and start alcohol, the impact on the brain is different from some of the other substances we have. That's what we call the kindling effect of the brain, with repeated detoxes and retoxing, in which the brain gets into a confused state and people will start to have more intense withdrawal symptoms. They will be more susceptible to having what we call alcohol-related brain injury. They will also have more risk of having seizures and what we call delirium tremens, which is a side effect. And also their detoxes will become more difficult. And that is one of the important aspects of people who drink alcohol and keep relapsing and going back into the addiction, relapsing and going back into the addiction. And it's always very, very important for us. And that's why we will always plan our detoxes. The psychological preparation for an alcohol detox is extremely important, and it is not something that has to be taken lightly at all, because anybody who is not prepared for alcohol detox will be back again in the next few weeks. And so talking about safeguarding and things like this, we know that the under 16 and people who grow up in homes where there are people who use substances, we refer to something as the toxic trio. In a family where there's mental health, there's substance misuse, and domestic violence, the impact on children growing up is massive. Those people will suffer with what we call adverse childhood experience, and as they grow up, they might actually have post-traumatic stress disorder secondary to the trauma. And when we talk about PTSD, it could be a major significant life event, but it could also be tiny multiple events that add up eventually to become a major event in their life. And we've talked about pregnancy. We've talked about what we've not mentioned is the older adults. Because of time, we won't be able to go into older adults, but we're now having people in their 65, 70 coming to substance misuse services, and that increases their other complications like falls, injuries, and things like that can lead to safeguarding issues. The prison population, as much as we're trying to manage the input of or inflow of drugs into the prisons, I've had a lot of clients that went in there, never used drug, and came out a polysubstance use. That is still something that we're still failing at as a society. And I think unless we begin to look at prevention rather than cure, that will be an ongoing problem. We need to have more funding to stop people going to prison in the first place. And that's the most important bit. But then we all know that funding and things like that are quite difficult. But well, that is another story for another day. I can be on that topic for another 3 hours. So what are the harm reduction philosophy in terms of managing people with substance misuse? We need to meet people where they are. If somebody comes to me and they've been addicted to a substance for like 40 years, I won't say, stop. If I say that to them, they will not come back the next day. The first thing I want to ask them is that, what do you want to achieve? What is your goal? I get them to that goal and I ask them to set further goals until I get them to where I want them to get to. Because one of the things that the dependent itself is scary enough for the user. And you're now telling them to stop an habit or a lifestyle they've known for 30 years that has taken everything away from them. And when we talk about substance misuse is when people hold on to one thing and lose everything. So they've lost everything. The only thing they have is substance. And then you're asking them just to stop it. It's scary. So the way we actually counsel people is once they come into a service, we want them to come back. And the only way of making them to come back is the compassionate approach, the non-judgmental approach, and also respecting their views about their goals, even though it doesn't sound sensible. I know that if somebody does not stop drinking totally, they will continue to relapse. If somebody tells me they want to be a social drinker, I will work with them to get to that point. And then we set another goal. And half of the time, when they've done that twice and relapsed, they will come to you and say, Doc, you're right. But then that is the way to work with these people, not actually wanting to get them to do what we think they need to do. So these are universal interventions. I'm not going to go through that, and alcohol harm reductions that we have that can be used across both universally and globally. These are just the Drug Misuse Acts. What is happening in the global landscape? Taiwo, please, how many more minutes have I got?
2 now.
Oh my, okay. Let's leave that. Let me just quickly rush down to talk about something. Tramadol is what I would have loved to mention because of some of our colleagues from Nigeria that are on here, but it's a global epidemic.
Yeah, I think we can still give you till for another 5 minutes because the questions are doable. I can see that there are only about 5 questions, so we should be able to get through.
Okay. Cat is another thing that is very popular among the East Africans. It's also caused, it has ketamine and it grows rapidly. The leaves must be fresh and chewed within 48 hours of harvest. We used to think that it was the fresh leaf, but over time, evidence is now showing that young people who cannot afford, it looks like lettuce when you bite, that cannot afford the fresh one, that now take the chewed part that the older men use and they dry it and then smoke it, actually becomes psychotic. So there is some level of psychoactive activity in that dried form itself that we're now beginning to see. And tramadol, it's a weak opiate serotonin noradrenaline reuptake individual, but it is extremely addictive. And within the African context, a lot of people use this as chemsex drugs. They use it for sexual activities, and it's extremely dangerous. And I think one of the things that is very upsetting about this is how young people are having access to this very dangerous medication in the African continent and how dangerous it can be. And oxycodone in North America, we've heard about that. The lean, I'm sure people in the UK will have heard about lean. What is lean? It's when people mix codeine plus promethazine, which is a cough syrup, and then soda. And it gives them this psychoactive high that they enjoy. But the problem is that they don't know the strength of what they're using or the potency. So people can overdose on it and all that. And don't forget also that cough mixtures, especially the cough suppressants, they also contain codeine. So some people are addicted to cough mixtures. And I actually know of a pharmacist went back home in Nigeria that actually will have to reserve 2 or 3 cups for a young girl in a community, unless she goes into withdrawals, because she's addicted to cough syrup and she wouldn't go for therapy. So you do find things like that happening, and people are trying to manage it as much as they are, but we need to have a universal approach, a more global cry for addressing the drug epidemic across the world. So let's just inhalants. We won't have time to look at that, but I'll just mention that people who inhale solvents, aerosol gases, and nitrates are more at risk of having neurotoxicity, in which the white matter damage of the brain can happen through the toluene that is in the glue they're sniffing, and petrol, and all of the other things. Benzodiazepine, I've mentioned it, but we also have the Z benzodiazepines, the non-benzodiazepine hypnotics like zolpidem and zolpidem. You know, I was mentioning about women going to doctors and saying, I can't sleep, and they get prescribed all these sleeping tablets. They are extremely addictive. And it's important that people try and manage this before it becomes a problem. Okay. Let me try to see. All right. So what are the key clinical and scientific points from all we've talked about? Addiction is a brain disorder. It's not just a behavior that somebody chooses to have. Initially, it could be a choice, but once it becomes an alcohol or substance misuse disorder, it is beyond that. It's become a disorder. It's become a chronic relapsing condition that needs to be managed. They need support, not condemnation. It's not a character failure. It's not about parenting, even though we know that there's a biopsychosocial model to substance misuse, which, if you have the time, get the book. It addresses all this, because we cannot do this in the little time that we have. But all these things that I've mentioned in the clinic now is addressed in the book extensively, about the parenting, about the approach, about how to start a conversation about drugs, how to manage it without the child feeling stressed up or alienated. And that is very, very important. All those things are covered in the book. And the drug landscape never stands still. They're always way ahead of us, and we're chasing them. Dual diagnosis is the rule, not the exception. But we don't call it dual diagnosis again, just for people to understand. That's why I use the term dual diagnosis. It's comorbid substance misuse and mental health disorder. 75% of those that come to us have a co-occurring mental health condition in addition to substance misuse. And it's very difficult to know which one started first, which one is secondary. And that's the reason why treating both at the same time, because they're two different disorders. If I have appendicitis and I have diabetes, nobody will say to me, let's deal with your appendicitis first, and then we'll deal with your blood sugar later. Or we'll deal with your blood pressure later. Let's deal with this fracture first. You deal with the two at the same time. The same thing applies to people with co-occurring condition, but getting other clinicians to understand that sometimes is a challenge. And we have harm reduction saves life. Naloxone, which is a reversal drug for people with overdose, is one of the life-changing innovations that we have in substance misuse with opiate use disorder. I need to mention this briefly. Some withdrawals are life-threatening. Alcohol, GHB, GBL, benzodiazepine, even the non-benzodiazepines that I mentioned, the Zopiclone and the Zolpidem, can be life-threatening if not managed very well, because they can lead to seizures and fits. Recovery is possible for everyone, at any age, at any stage, with any substance. Hope is a clinical tool that we hold strongly to in substance misuse services. The language that we use matters. Using person-first, non-stigmatizing terms is important. And that's why you find out that some of our clients will never go to anywhere else except our service, because our approach is different. And even it took me time when I moved from adult psychiatry to substance misuse to change my way of thinking and my approach to clients, because I had to be able to engage them. I don't expect them to come to my level. I had to come to their level and speak their lingo. And that took some time for me, and it was initially a challenge, but I understood what I had to do. And families are even patients. 4 to 6 people are significantly affected for every person with substance misuse disorder. So for every one person using substance, 4 to 6 people in that family setup or friendship cycle is also affected by that person's substance misuse. So that tells us how important this is. So if you have one person with 6 other people, that is 7 lives being affected. And the Global Equality in Treatment Act says only 1 in 12 people globally with drug use dependence receive treatment. We need to improve on that. And it's important that every one of us, even if it doesn't apply to us or apply to people that we know, will come across somebody that will need help. We should know our local and national resources and where we can get help. Please, social media is not where to get information about substance misuse. Go into validated sites where you can get information about what you need to do, like Frank, Samaritans, AdFam, NICE guidelines, and things like that, where you can get validated information that are true and have been tried and found to be true, not just what people who have just come from the call put on the internet. All right. So ask and keep asking. If you're not sure, just keep asking. Eventually, there will be somebody that will listen. Don't give up on yourself. Substance misuse is something that we all see, and nobody is immune against it, no matter your position. And I will stop there, Child, because of time.
Thank you so much. That's really very loaded. Let's just appreciate Dr. Ajayi, please. Whilst he just catches his breath, let's just show him some love with our emojis.